Hi there, I'm Dr. Stephen Phelan. Welcome to another Dental Excellence video. Today I want to share another case study, another full mouth rehabilitation case study. And this is another example of the type of case you can complete by implementing the systems and coaching you learn with my occlusion design program. And this case was featured in the July 2021 coaching webinar. So here is the case. The patient presented with over 100% overbite and a very tight overjet. And he did not want to have orthodontics to change his occlusion. He also had a lot of tooth wear and was starting to break and crack different teeth. So he's had to have a couple of endo treatments and crowns, and he ended up fracturing his upper central incisor, and it has an immediate implant with an immediate provisional in place. That the tissue levels weren't quite right. Implant's not quite as deep as I'd like. I'd rather this implant be deeper, but it was something that we could work with. And then he has two one-piece Nobel 1 implants on the lower central incisors. This is a discontinued implant, and it became a pain in the ass to replace the crowns on them because all the parts are discontinued. So I ended up having to do a crown and bridge impression on the implant abutments that are, again, one piece attached to the implants. Not a really good system, but we managed to make it work. We'll talk about that a little bit. So this patient was breaking down. He wanted to come in and have basically a rehabilitation as opposed to ortho and a partial rehabilitation. You can see he has a number of teeth that don't have a tremendous amount of tooth wear, although this bicuspid here was cracked in half or has a craze line running from mesial to distal. I'll show you that. A number of the teeth could be treated more conservatively, and a number of the teeth we felt we would do with full contour crowns. Looking at risk assessment, we felt he was at a high risk for, potential problems. This is my risk assessment form, a digital version of it. I've talked about this before. It's mostly shown in Module 2 of Occlusion Design. You look at all the red here. So he has a lot of red and in bad places, my large muscle, high bite force, high erosion and tooth wear and attrition, deep overbite, evidence of bruxism, endodontically treated teeth. There's a lot of areas of red, which causes this to have 11 out of 16 are red. So I said that the risk profile for this patient is high. And if you look at some of my other trainings, this is my journey for a rehabilitation case, starting with initial consultation, diagnostic records, what we call a functional analysis, risk assessment and treatment planning. A lot of this is done with the records, post records appointment. Final treatment planning consultation, I do this virtually now. And then any pre-restorative treatment, in this case, I was changing the contours of that implant provisional to level the gingival levels by adding contour to it. Preparation day 1 and 2. If I'm doing a full mouth case, I split up the preps under day 1 and 2. If it's a case with a lot of core buildups, I might do that, at least some of them in the pre-restorative treatment. Then testing of the changes in the occlusion and aesthetics with the trial phase. Then I'll complete one arch, test the completed arch against the opposing provisionals, another testing phase, and then final restorative records and completing the case. So that's the journey of a restorative patient in my practice. We obviously start with the diagnostic wax up. This case was treated with an analog wax up. So here's some images of the wax up. They were taken on my phone. They're not the best images. I do have a couple other shots of the wax up in videos. Preparations. Again, we do preparation day 1, preparation day 2. In this case, we did preparation day 1 as the upper arch. So we did the upper core buildups that were needed, upper preparations. I did another modification of the upper implant, provisional, and I did an upper, created all the upper provisional restorations, and obviously took the upper final impression. So here is day one. Initially I did this adjustment to the provisional. It wasn't bad, but I wanted to make a little more contour change here to make them more symmetrical, make this provisional more symmetrical with the other central. So I need to add some contour in through here to change the shape of the papilla. Other than that, it's pretty good. It started out, we had an altered gingival level height. Now we've got the height decent, but the shape isn't quite right. So you do this by adding flowable composite on the provisional, subgingivally, and it can, basically reshape the gingival levels by pushing the gingiva up with the additional provisional flowable material. So that's how we do that. So we finalized that. Here's everything ready to go. You can see a better version of the wax up. We have a duplicate model of the wax up, and then all the putties and stents I used to check the preparations and basically make the provisionals. So here's just a little video of all this for day one. And with day one, in the webinar in July of 2021, I showed an extensive series of videos of prepping the case, making the provisionals, and completing the bite records at a post-treatment appointment. But today, for these dental excellence videos, I'm giving you a condensed version of the case study. So this video I've shared before, and it's basically using the vertically sectioned putty. So I'm sectioning it vertically down the mid-axis of the prep to check the preparation depth and verify that it's ideal, especially with veneers where we're trying to prepare conservatively. It's easy to under-prepare. So we're looking at the preparation relative to the wax up, and the wax up is represented by the vertical putty. So we section a full putty vertically down each tooth. So I start at the back and move forward so that we can use one putty on a full arch. Sometimes by the time we get to the other side, there's not a lot of putty left. So that's one of the reasons we make two putties. I can start sectioning the opposite direction with the other putty, and then I've got a good stable putty for all of the views. If I'm doing 6 to 8 teeth, I can generally get away with one full arch putty, but if I'm prepping every tooth in the mouth, it's good to have two putties for this. So here's a little video. This was filmed about 3 years ago. You can see depth of preparation looks pretty good, just needs a little more incisal third change. This was shot with a different video camera, not quite as clear, beautiful videos as what I'm getting now with the Nikon Z9, but still pretty good. So here you're just seeing the incisal putty, the other putty. You can see how I've improved this gingival level. I did that near the beginning of the appointment. Some finalizing. You can see now we've got better depth of preparation, but we still have, all enamel in the prep, at least up until the mesial section where we had to prep it down to the palatal to get a good contact against the implant crown. So here's just smoothing it. You want the incisal facial line angle to be rounded so that you don't have a sharp edge there for internal aspect of the porcelain veneer, which could stress concentrate it and cause fracturing. So this putty is actually really good to check that and see that you have a rounded facial incisal line angle. And here, if I have an implant and I have a veneer on either side of the implant, you'll notice I didn't break contact between my veneer preps, at least most of the places. But I did break contact here and here because there is, a broken contact because the tooth is missing. So when we have that situation, I'm generally driving my finish line to the palatal incisal. So the palatal incisal and the mesial palatal in this case, and the mesial palatal here. because we want to have the contact go right through the width of the contact and width of the papilla, as opposed to ending it here and having kind of a funky contact against the implant crown. This allows us to have a better contact with the implant crown and better papilla around the implant crowns. So that's why we break the contact and drive this all the way to the palatal on either side of the implant, even though it's a veneer. Typically, my veneers, I don't break contact like that, but when it's next to an implant, for sure I break contact. And there's a number of indications where I would break contact with porcelain veneer preps. But as you can see here, we didn't. I don't believe we did over here either. So we're trying not to break contact. I'm trying to keep this as conservative as possible. You can see here, all of this is enamel, all of this is enamel. There's some dentin here because of the way the shape had to be. And there's some dentin exposed here, but all of this is enamel. All of this is entirely enamel. We have a lot of enamel to bond to for the preps. This is a custom impression transfer, open tray for the shape that we gained and created with the provisional, the changes to the provisional. Now here's the rest of the provisionals. I've sectioned it into sections. Most notably, the posterior are all one section on each side, so I can take these off. I can remove these to take the bite record at a later date. So I can remove these, take the bite record at a later date. I also modified the provisional implant crown, basically made a veneer based on the wax up over it that I just glued on, because the shape wasn't exactly what we wanted for the final shape. It was made to the original tooth design and original smile, which we were lengthening. So I basically had to make some modifications to the existing implant provisional. I showed how to do this in the Occlusion Design member webinar, but the long and short of it is I basically made a little veneer for it, provisional veneer, and glued it on, and that made the whole thing work out. Here are shade photos. Here's everything here. And here are the preps. So this is interesting. You can see, again, conservative veneer preps. Oh, yeah, the cuspids, because we needed more contour on the palatal of the cuspids for occlusion, I did basically what we call more of a glove crown around this. This will be a feldspathic veneer that wraps all the way around the prep. And we've got still enamel on the palatal too. So it's a 360-degree crown. Veneer that's like a crown, but light chamfer all around. Even this crown here, this was a tooth with a craze line or crack line from mesial to distal, but it was determined it didn't need a endodontic treatment, so we did kind of this 360 veneer type crown. It's a light chamfer most of the way around because I wanted to keep it conservative. And then this is a light veneer that's going to overlap the occlusal. So we just rounded this whole intersection between the veneer and the occlusal. And Harold's going to just build this as an occlusal veneer, an onlay veneer. Same with this side, both of these bicuspids. I didn't feel the need I had to prep them full coverage like this one because there was no cracking. And then the molars, we decided to go full coverage, just talking about risk and overall bite force and all of the different concepts to think about, strong tooth, strong restoration, strong weak kind of preparation, and, all of these different concepts we talk about. I did have a discussion with the patient, and we came up with full contour zirconia crowns on the molars for supporting the bite and managing his bite force. But the bicuspids were going to be feldspathic, and we were doing them as conservative as possible. So that's what we came up with. And then conservative veneers on the anterior, except for the implant crown. So you take a close look up here, you can see we rounded between the veneer and the occlusal surface, so Harold can wrap these without really prepping the occlusal surface. And then this is the tooth that was cracked. Sorry, this is a mirror image, but you can see here, craze line from mesial to distal. This is the type of tooth that could basically break in half. And so that's why we decided to go full coverage on that tooth. And then you can see, again, really conservative veneer preps with a lot of enamel still remaining. Even this glove crown still has a lot of enamel still remaining. And then these veneers, are all enamel and basically wrapping onto the occlusal because we're opening the vertical, so we're overlaying the bicuspids, but it's a really conservative prep design. So it's interesting for you to see. That's why I wanted to show these. Same with on this side. So this is a conservative jacket crown prep design or glove crown prep design for these two, but this is, a very conservative onlay veneer prep design. Veneer, crown over here. Again, my posteriors, full contour zirconia crowns, I go pretty pushing the envelope on the design. I'm not putting a big shoulder. I'm putting a pretty minor chamfer, medium chamfer all around it, and trying to give enough occlusal reduction. But, we're going to use a stronger zirconia on the molars, and they'll be full contour. So I've not had, knock on wood, a problem with these cracking, even though I'm pushing the envelope of how conservative I'm prepping a full contour molar zirconia crown. And then here's the provisionals. So at the end of day one, we had the new provisionals. We have the modification to the implant provisional, and we have the patient trying to function that against the lower that's not the way it's supposed to be. So I just let the patient know, your bite's going to feel really funny. We'll try and maybe shave down some spots on the lower anterior if needed so that you have some even contacts, but you won't have a great occlusion. He basically had a posterior open bite until the next day. So it's only one night. I advise them to have soup and a light amount of food, and we'll be okay. So you can see the before and the after. So he was okay, came in the next day, and we start the day 2 preps. This just shows you the veneered provisional crown. So all I did was I basically glued with flowable composite a Pro Temp provisional that was made from the wax up design and made in the shell of the other provisionals. You can see this is not as deep as we would like, and it has a pretty abrupt emergence profile because it's not placed as deep as we would ideally like that implant crown. So day 2, we're going to do the lower core buildups, lower preps, lower final impression, lower provisionals. I decided we wouldn't do the bite records because we're making a fairly big occlusal change to his occlusion. I'd like to test that out for a few weeks before we take any bite records. And we're finishing the upper arch first. So the bite record I would take is basically taking off the upper posterior provisionals and taking a bite of the anterior provisionals to the lower full arch provisional to give us the bite at the correct vertical dimension and the correct AP position that we want to build the case to. So the provisionals would be equilibrated and tested before we do these bites. And then you can see my setup for a multi-day prep like this, day 2 setup, core paste, all the things that we need. And then on my unit, I've got my slow speed, I've got my sonic scaler, and I have my electric high speed. And then a variety of different burr blocks. Softflex XT discs are something I use for the preps to smooth them and to adjust and refine the provisionals. Most of the time I'm using the coarse. And then the Enhance cups are something that I use a lot as well, especially around implant provisionals and just to smooth and round my preps. And so here he is at the end of day 2, upper provisional and lower provisional. Sorry, I didn't take photos of the lower preps. I don't know why. I have video of it, but I don't have photos. But I have, you'll be able to see the models if you wanted, but I don't have photos. And here we had those Nobel 1 implants. So I had to take off the existing metal ceramic crowns. I had to pack cord around them and take basically a crown and bridge impression. And then I had to make the provisionals right on those abutments. So here, we've got a little bit of space in the papilla. I've left it so that this will rebound into there. Tried to keep the contour really available for the tissue to rebound around it. You can see his 100% overbite before, and you can see the changes in his occlusion with the design that we did. So he has a big occlusal change that we want to test out for a period of time. Usually, 1 month is a good amount of time. If you're really having questions about whether the patient can adapt, you can go up to 3 months, and that works as well. I think we get the design dialed in quite nicely. So I feel that I could test for a month, take the bites, and then have him test another month while the one arch is being built. And then he'd test another month with the finished upper arch, for example, against the lower provisionals. So I am testing ultimately roughly 3 to 4 months, but some of it is testing provisional against provisional. Some of it is testing finished arch against provisional. So we are giving this a good amount of time to test, but we're trying to move forward with the case. So here is just some views of the provisionals, the day that we finished the lower provisionals. So this is after 2 days of preps. Tissue's a little beat up, but not terrible. And then here are the impressions. I had to take 2 of the lower. I just felt like I was uneasy about this crown and bridge impression on the 2 implants. And I think there was maybe an area over here that needed a new impression. You can see here the close-up. I actually feel like we got a good impression, even though it's really hard to pack cord around implants and make space for this impression material to go all the way down to the abutment margins, but it did work. And then here's a video. This is the upper. The upper I was able to nail in 1 shot. Oh no, did I do 2 on the upper? Maybe I did 2 on the upper. It looks like I did. And it looks like I used a closed tray impression transfer. Sorry, I was thinking that was open tray. I think this was a 2021 case. Since then, I've actually almost completely moved to open tray for implant impressions if I'm not using a scan body. So in the anterior, I always use a custom impression transfer, and I would use an open tray wherever possible. And on the lower, we did 2. So it looks like we did 2 on each. The lower, I was concerned about these anteriors, but it ended up working out okay. And then here's the provisional once more. And then we go into testing, and you can see after a few weeks, the pupilla is filled back in here from the impression procedures. Tissue looks pretty good pretty much everywhere. And so we take off the upper posterior provisionals. That's after, equilibrating the provisional upper to lower and testing everything out. Once we're good, we feel we're good to go. I take off the upper posterior provisionals, and I basically have the patient bite down. You've got solid contacts on the cuspids that you can see in the bites, and your bite is at the vertical dimension that you want to build the case at. And because there's no posterior contact, it's an open, basically Lucia jig type of bite in CR. So the anterior provisional is acting like a Lucia jig to build the bite, or a deprogrammer. So here is everything being sent to Harold, my ceramist. I do take 2 sets of these bites, upper preps to lower provisional, and he checks them with a device called the MPI. You might have seen that on some of our webinars. The MPI allows us to verify the bites are identical. If they're not, then I would have the patient back and take more. And it has happened before where the patient's been going into different places and I didn't realize, mostly if I try to take the bites on the second prep day. Usually the patient's muscles are messed up from being open for 2 days and we don't get great bites. Here we did get really good bites, but I took them after the fact, after testing. So because of the big occlusal change, I didn't try to take the bites the prep day. You can also see the provisional to provisional bite where we verify how the contacts look after equilibrating the provisionals. You can see a better image of the wax ups. And this is the provisional model here, upper and lower. So we send all this to Harold. He'll cross-mount everything to the mounted models, cross-mount the prep models with these bites, the upper prep anyway, and get everything ready to go to build the porcelain restorations. You can see the occlusion on the provisionals here by looking at the upper the provisional to provisional bite, holding it up to a light. You can see the contacts. And then the final restorations, as I said, we created the uppers first. This was a challenge on the upper because we had to make a custom impression, a custom abutment and post and cemented crown. So I couldn't do a fully screw retained cemented crown. The hole was going to come out around here somewhere. So we had to make a 2-piece, which I don't love. I'd rather do a 1-piece with a screw, but especially when it's shallow like this. But this is what we had to do. This crown is close to where we expected the veneer final color would be. It's not 100% perfect. We thought about sending it back, but we decided to keep it and cement it. The patient, for the most part in all lighting, was happy with it. I told him to try it out. If he wasn't totally happy with it, I could take it off and send it back. But he decided he was happy with it and would go with it. And I'll show you some pictures so you can see. So this is a zirconia custom abutment on a tie base with a zirconia crown. And then the rest of these anterior are feldspathic, layered feldspathic. And then these are, I believe these 4 are Emax onlay veneers plus a jacket crown. And then these I know are full contour zirconia. So I think these are full contour Emax with some layering on the buckle. And then these are full contour zirconia for strength. So it's an interesting combination of materials. Here's the final. This looks pretty darn close. It was close enough. It's maybe slightly lower in value if you make this black and white, but it's very close. And then you've got all the feldspathic, all the Emax matching, and then the zirconia at the back. So it's a mixed bag of materials. And on the lower, we did metal ceramic on the 2 Nobel 1s. We felt that was the best way to go because of the way the margins are. And then we did feldspathic again on the anterior. And then I believe these are, again, Emax. And then these are zirconia in the very back, posterior on the molars. Full contour zirconia, full contour Emax, I believe, and then feldspathic at the front with metal ceramic. So another mixed bag of different materials. Here it does look a little off on value, but it actually looks even better than the upper in the mouth. And so you can see the finished case the day that we seated the lower. And on the lower, again, we had onlay veneers, but they didn't wrap as far as the uppers. They wrapped more to the mid buckle. These ones wrapped a little further on the upper, just to get more occlusal surface reconstructed, even though I didn't prep that. And then the before and after, just looking at the facial view, I think this shade match of all of these different implant crowns actually matches pretty decent with the rest of the reconstruction. Even retracted, looks like a pretty decent match, I have to say. And you've got mixed materials here throughout the case. But we tried to give it what I felt were the best materials for each individual tooth or implant to make it work. It's kind of a compromise, trying to make everything work when you have different substructures. These implants on the Noble 1 were metal posts, metal abutments. So that's why we went with metal ceramic to block it out. The uppers is zirconia abutment. And then the rest are tooth supported, some of them veneers, some of them crowns. So big mixture of materials, but we were able to make this work. So here's the upper. You can see the tissue looks really healthy around the implant, and I think it's fairly symmetrical with the other central, even though both of them are a little shorter than the laterals, but it's okay because of his lip line. And I think it looks like natural, beautiful aesthetics. And then the lower, I was really pleased with the way this turned out because I was concerned we weren't going to be able to make these look good or even fit good. And it looks like the fit is really good. The tissue is nice and healthy. And aesthetically, it looks like a pretty darn good match. And then some side views. Looks pretty darn good. And we protected this with an E-splint. So an E-splint is basically an upper and lower acrylic splint with a ramp at the anterior so the back don't touch. So the patient can grind around and they really only touch the ramp and they're grinding around on the ramp. So it's like a permanent deprogrammer, but you don't want to leave the back teeth uncovered. So we have them all covered so nothing will move. And then the anterior is just this deprogrammer. And it takes them a while to grind them down if they're a bruxer. So you'll eventually have to replace this, but it takes a while to grind it down. And most patients who are bruxers find this a comfortable thing to use. If the patient has a TMD problem, they can't use this because you have no posterior support. It's basically touching at the anterior with no posterior support. It's open at the posterior, so you need a healthy joint to be able to use this. But patients with a healthy joint find this very comfortable. Patients with a compromised joint, I would not make this. We'd make an upper CR splint, probably against a lower Essex with good posterior support, almost posterior group function on the splint at least to help support the joint. A patient who grinds just a little bit, we don't think they're a heavy bruxer, and want something comfortable to wear as a protective appliance, I would make an upper and lower Essex made out of a material like Durasoft, which is a little thicker. And that will protect the porcelain, cover upper and lower arches because we have a full arch case. A full mouth case, I tend not to put only an upper appliance. I put an upper and lower. And it varies depending on what I would want. But upper and lower Essex works great. The only problem is if the patient is more of a grinder than you expect, they're going to wear holes in the Essex. So you'll see holes, and I see this when the patients come back. It's a good test. And you'll see holes maybe, or at least wear marks in the cuspids, and they'll have to be converted to a thicker acrylic splint if you made that. So that's basically some ideas on protecting these cases. I did post this case to my Instagram. You can see we posted it a couple of times and it had a lot of likes, 464 likes, 216 likes, so lots of likes. If you want to check my Instagram, it's just DRS Phelan. And here's the ceramist who did the case, my master ceramist who I do a lot of full mouth cases with, or pretty much all my feldspathic, and most of my cases are done with Harold Heindel of Aesthetic Dental Creations. And so you could contact Harold if you'd like to do a case with him. Now that I am back full time at full-blown at practice, I'm doing a lot of cases again. He probably won't have quite as much time. I'm going to monopolize him. We have so many cases coming through now again. I was off for pretty much a year with an ulcerative colitis problem, needed 3 surgeries, and not something I want to revisit. So now that I'm back, we're really just so in demand to do these cases. It's a lot of fun. But talk to Harold. He could certainly fit in some smaller cases with our members and our followers of our online community, because there aren't many people out there doing feldspathic anymore. Feldspathics a bit of a lost art. If you'd like to do some feldspathic veneers, I highly recommend Harold. And just remember, you can do this kind of dentistry. You totally can. You need the right lab support. I think being a member of one of my courses, like the Porcelain Veneer Masterclass, or if you want to do these more complex cases, like the Occlusion Design course, our online coaching program and training program with Occlusion Design, being a member of those, I think can help you learn how to do these cases. So, again, you can do this kind of dentistry. Beautiful dentistry with precise fit and occlusion is not just for the gurus. Let's do this. Get out there and do some cases. Enjoy dentistry. It has so much to offer. Being able to deliver this kind of dentistry to your patients is so rewarding, and it really builds your practice and builds your practice reputation. So let's do it. And thanks for being a member of our online community. Take care.